I mean, this is a 3-year collaborative project between the EAN, the International Neurology Society, and the European Federation of Autonomic Societies. And the rationale for this is that their guidelines just don't exist for neurologists. So we have several robustly made guidelines for neurogenic bladder and sexual management, which is available essentially for the urologists, for management. But when it comes to a neurologist in practice, many of the recommendations are certainly aren't that sort of applicable and relevant. And so this is something that is sort of made in collaboration between urologists and neurologists, and is essentially designed for the practicing neurologist, be it a general neurologist or a specialist like in multiple sclerosis or Parkinson's, to actually assess and treat bladder and sexual dysfunction. Well, so number one is that as a neurologist, one should ask about bladder and sexual dysfunction. I think that's it's itself an achievement if that is something that we can convey. And also is sort of knowing which are the baseline assessments, such as if it's a patient with bladder problems, they're measuring their post-void residual volume. If it's about sexual dysfunction, a targeted physical examination, and then also understanding the first-line treatments that as a neurologist one would be able to initiate, providing awareness about the different sort of therapeutic approaches, about side effects. One key bit is when to refer. So sort of red flags are on, when a neurologist should involve their specialist urologist or urogynecologist. And that's been sort of included in both the section on bladder dysfunction and on sexual dysfunction. So we start out with taking a good history. We provide some guidance on what a good history on bladder dysfunction is like. Moving on to a targeted physical examination, investigations such as bloods, measuring the post-void residual, and there are recommendations on recommending first-line assessments like looking at fluids, about pelvic floor muscle training, and specific treatments or like antimuscarinic agents, beta-3 receptor agonists, alpha blockers. When it comes to sexual dysfunction, quite similar sort of approach in terms of assessment, examination, and treatments for male sexual dysfunction, such as your phosphodiesterase 5 inhibitors, and moving on to second-line treatments such as a vacuum device, and specific sort of red flags on when to refer. So, for example, if it's a patient with sexual dysfunction who has also blood in their sperm, for example, or pain during intercourse, it needs to be looked into. For bladder dysfunction, if they have sort of blood in their urine, or if they have a high post-void residual urine, or if they're deemed to have a high risk of developing upper tract damage as per their neurology or their findings in their baseline investigations, then they need to be referred on.